Okay everyone, this video discussion of clinical toxicology will be a little unusual because it relates to two chapters in the Goldfrank textbook. There's just too much overlap between the chapter on antithrombotic drugs and the nearby chapter about antidotal strategies to really warrant separate discussions. Some redundancy may be desirable, but not that much. The learning objectives here are that you'll be able to identify at least two agents, other than protamine and vitamin K, which are covered in other videos, used to treat serious bleeding complications of antithrombotic drugs, and to explain their mechanisms of action and which drugs they reverse. As you know, there are various antithrombotic drugs used to reduce the risk of forming blood clots and avoiding complications of that pathologic clotting. These drugs are frequently used in patients with, for example, atrial fibrillation so that they don't form intracardiac clots and throw them up the carotid arteries to the brain causing strokes. They're also used in patients who've had ischemic strokes or TIAs, and to treat thromboembolic disease like deep vein thrombosis and pulmonary embolism. It's great that we have these antithrombotic drugs, and I'm sure that they work fine for the great majority of patients. But from the toxicologist's perspective, we're necessarily focusing on what can go wrong, so what you've done is set up a ticking time bomb where it's only a matter of time before we'll see some serious complications like massive GI bleeding or intracranial hemorrhage. And when this occurs, we'd like to be able to reverse the effects of those antithrombotic drugs as rapidly as feasible to stop the bleeding. This raises the question then of which antithrombotics have reversal agents, which is to say, which have antidotes or other specific treatment strategies. Warfarin and other vitamin K antagonists are anticoagulants that inhibit the post-translational activation of multiple clotting factors, notably factors 2, 7, 9, and 10. And this topic is covered elsewhere in the series, so I'm not going to repeat my comment/discussion here. Similarly, I'm going to refer you to the other video in the series about the use of protamine to reverse heparin via chemical antagonism rather than physiologically. Warfarin and heparin are older agents that typically require ongoing monitoring, so it was a breakthrough when some newer agents that may be safer and require less or no drug monitoring became available. Dabigatran was one of those agents. Dabigatran is one of the DOACs, a direct oral anticoagulant, and it's called direct because it acts by directly preventing clot formation by binding to and inhibiting thrombin. You may also see DOACs referred to as NOACs, standing for novel oral anticoagulants, but since they're not so new anymore, it's getting harder and harder to justify that they're novel. A specific treatment for bleeding related to dabigatran is idarucizumab. Idarucizumab is a monoclonal antibody that binds up the dabigatran so it's no longer available to inhibit thrombin. The trade names here I think are helpful. Dabigatran is Pradaxa, so something that binds to Pradaxa is called Praxbind. The dose is 5 grams, or 2.5 gram vials. And here's another antidote that works through a drug-binding mechanism, although a slightly different one. Andexanet alpha is a decoy molecule, engineered to look like factor 10A, so it will bind to the factor 10A inhibitors like rivaroxaban and apixaban. There are two doses, and whether you give a low dose or a high dose may depend on which 10A inhibitor, what the last dose of that inhibitor was, and how long ago it was taken. I don't think it's necessary to memorize these tables, but you should know that they exist as a resource when the right clinical situation comes up. Now, however, we're getting into territory where we have some less specific treatments that fall more into a blood bank territory than technically as antidotes. There are a few products available called PCCs, or prothrombin complex concentrates, that may be used to treat serious bleeding from different kinds of antithrombotic drugs. The idea here is that you're replacing deficient or inactive clotting factors. The PCC that is most commonly desired is a 4-factor PCC, where those 4 factors are 2, 7, 9, and 10. Those are the clotting factors needed by someone with warfarin toxicity, in addition to treatment with vitamin K, and the most clinical experience in using PCCs for drug toxicity is with warfarin. 3-factor PCCs are also available, such as Profil 9. This contains factor 9 and also factor 10 and factor 2, but it has very little factor 7, so you might consider supplementing 3-factor PCC along with recombinant activated factor 7 in selected cases. Obviously, any patient with severe bleeding complications from antithrombotic drug toxicity could need blood transfusions or other blood bank products, like FFP, fresh frozen plasma, or cryoprecipitate, which provide active clotting factors. And dialysis might be considered to remove some antithrombotic agents, such as dabigatran, although the evidence is weak and perhaps even contradictory. Okay, that was a quick tour of agents you'll hopefully be using rarely, if ever, since the situation will be quite scary if these are needed. I'll be seeing you around.